Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you will find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
One in 4 people die of heart disease in the United States. There are many heart conditions, but what qualifies as heart disease? What are the signs? What are the symptoms? What do we look for, and when do we ask for medical attention? During the next hour, we have experts answering questions about early detection and possible prevention of heart disease. This evening program is called The Ins and Outs of Heart Disease and is underwritten by the Hospitals of Providence, and specifically the Center of Heart Practice, which is predominantly located at the Trans Mountain campus. A huge thank you also goes to the El Paso County Medical Society for bringing the show to you since 1997. I'm Catherine Berg, and this is the El Paso Physician. Thank you again for joining us. This program is called The Ins and Outs of Heart Disease. And with us this evening, we have a veteran who is Byomesh Tripathi, and he is an invasive interventional cardiologist. And we also have someone new to the stage, and this is Tariq, and it's Siddiqui. Is that correct?
Tariq,
and
Siddiqui.
He is an invasive and structural interventional cardiologist. Dear Lord, that's a lot to say. So what I'd like to do is actually talk about, there are different disciplines and specializing in cardiology. And Dr. Tripathi, I would like for you to talk about what it is that your specialty does specifically. And then we're going to talk to Dr. Siddiqui as well and talk about the differences that you guys have together within your practice. So feel free to start with that.
Sure. Thanks for having me here. So I'm an interventional cardiologist. So I specialize specifically in treating heart conditions using catheter wires. And I was trained in treating something called coronary artery disease. That was the main thing that we were trained on. What it means is that we can treat heart blockages and heart attacks. Using just wires catheter, we can go inside, open the blockages using balloon and stents. So this is something I do, but I see other heart problems as well. For example, I see, conduction problems in the heart. I can put pacemakers. We treat general conditions for prevention of heart disease. For example, we manage blood pressure. There are several conditions that we manage, but as far as interventional cardiology is concerned, mostly coronary artery disease, conduction problems, and then we also treat peripheral arterial disease as well.
Okay. And we may talk a little bit more about that. I'm glad that you mentioned that because I don't have that down here. So we'll get to that in a little while too. Dr. Siddiqui, let's talk about you. So you added the word structural into your discipline, so to speak. So explain what the differences are between you and Dr. Tripathi in your practice.
Thank you for having me. So over the last decade, in fact, a little bit more than a decade, we have advanced a lot in the cardiology field, especially in the area of structural. And when we use a structural, basically, it's part of the heart, which we deal with, which includes closing the openings and holes in the heart, which in the beginning used to be fixed by surgery, open heart surgery. Now, we do it minimally invasive, we call, which means without opening the chest. We go through the vein and we go through the artery and try to open these holes. It's a wide spectrum when we call structural. We take care of the valves which are blocked. We try to open with the balloon so we can put the stent, and those stents has a valve implanted so that the flow can stay or maintain in the forward flow. We also have sometimes leakage in the valves because of different reasons, and we put the valves in those cases, and sometimes if the valve is not needed, we put a clip so that it does not clip. So it does not. It decreases the leakage, not completely, but to the level where a patient would not feel symptoms. Also, now we have been doing, which we call it, people who are at a risk of bleeding, and people, older population, who are sometime not the greatest candidate to be on a blood thinner for the long term. We have other option where we can take them off from the blood thinner and plug those structures which build the clot and prevent them to have a stroke.
So I'm writing all these little diamonds that you're throwing my way, because we're going to talk later. A lot of people are on blood thinners, and before there are procedures, we'll go off of your blood thinners for a little while. So we're gonna intertwine some of these things that you're talking about. What I'd like to do, again, you all are invasive interventional cardiology, and a lot of times we hear the word uninvasive. But when you say invasive, and I guess the key word here is interventional, you're trying to prevent something bad from happening. You know, people come to you, there are obviously symptoms and signs, but we're trying to prevent the really, really bad things from happening. So what I like to do, just for a second, because people think about cardiologists and it's just a heart doctor. So even though we described what you do, what are some other specialties that are in the world of cardiology, just so when the audience is listening to this, they're like, okay, these guys are the interventionalists. So from there, and Dr. Tripathi, feel free to just throw that out there. And we don't have to spend a lot of time on that, but it's just kind of a curious thing.
Sure, yeah. Broadly, we can divide cardiologists into, I would say, 4 categories, but there are several new categories as well. But broadly, you can say we have general cardiologists. They basically focus on preventing heart problems. They treat patients with medication, they counsel them, they make sure that they don't develop anything that requires a procedure or surgery. That's their goal. We are then interventional cardiologists, as we described. We are able to just go inside with wires, catheters, fix different things. Then we have other category called electrophysiologists. They are, again, trained into treating electrical problems in the heart. So they treat atrial fibrillation, they do a lot of ablations and stuff. And then we have heart failure specialists. So once your heart is weak, they'll figure out why it's weak, whether you can be treated with medications versus you need heart transplant or devices. So they are very advanced specialists in terms of cardiologists as well.
Okay, and I wanted to say that because I know that we're going to be concentrating on oh my God, I'm going to even try 4 or 5 times to say that. But again, we're going to talk a little bit about electrophysiologists too, just because it's part of what we hear about all day, every day. But if we're looking at heart disease, like if you're going to describe or define what heart disease is, we have in our populace, oh, I've got high blood pressure and my doctor wants me to bring that down. Oh, I've got high cholesterol and my doctor wants me to bring that down. When is there a definition of, okay, I've got heart disease? And I'm going to throw that, whoever wants to take that. Who wants to take that question?
Sure.
No, sure. Okay. Dr. Tripathi?
Sure. So, before we can define heart disease, you need to understand the structure of heart, right? So you can, just to simplify things, heart can be considered as a 4-bedroom house, okay? It has 2 upper bedrooms, 2 lower bedrooms, then it has pipes, and then it has electrical channels. And then walls are made up of muscles, right? So, we can have problem anywhere. In the bedrooms, in the doors of bedrooms, in the pipes, and, the electrical wires. Depending on what kind of problem we are having, we'll get that sort of heart problem. So, for example, if you have problem with the pipe, which is the blood vessel in the heart, then we'll get something called coronary artery disease. It's very common. It's number 1 killer in the world. So if we get problem in the electrical channels, then we'll have arrhythmias, basically heart rhythm problems, right? If you have problem in the muscles, we'll get heart failure, cardiomyopathy. And then when we talk about blood pressure, technically it is part of heart. That's why we call our system cardiovascular system, not just cardiology, right? So we are cardiovascular specialists. We treat cardiology as well as the vessels. So when you have high blood pressure, eventually it can lead to heart problems. So we treat that portion as well. We prevent people from having heart disease by treating their high blood pressure.
And that's beautifully explained too. And Dr. Siddiqui, let's talk about like the most common heart issues, cardiology issues, cardiovascular issues that you see on a daily basis or on a weekly basis. What is the most common that you see? And then we're going to talk about more what is dangerous and what is at least for now, until we talk about behavioral health?
Yeah. So I think before we even talk about the heart disease, I think main thing is that how you can prevent that. And so we do come across a lot of patients with hypertension as we talk about, and that's the most important thing to address so that you don't deal with the problem with the heart. Yes, if you are not taking care of yourself with the blood pressure medications, or you're not taking care with your diet and not taking care with the exercise and everything, then you would deal with this situation where you will have other problems, as Dr. Tripathi was mentioning, that can result into the pipe getting clogged, or built up of calcium or built up of plaque, which we call, and as a result, the artery can get blocked. And that's one of the most common things which we see every day in our practice, to the level that majority of cardiologists see that more commonly, and we need to prevent that before we can really treat that.
So I'm going to break that down to someone who doesn't know that there's clogging going on. And let's talk about some symptoms of what it is that brings people to someone like yourself that, okay, I'm not feeling right. I'm out of breath all the time. I know I have high blood pressure, but when do people actually come to see you so that there is a test, some kind of procedure that diagnoses what's happening? And again, I'm going to throw that to you first, and I'd love for you to tag on to that as well.
So a lot of time, as I said, like a lot of people come even before they feel any symptoms. So those are the area where we need to focus by thinking the family had a disease, so how we can prevent them to have a disease. If they are prone to get premature disease because of the family, then we need to make sure we do some testing to enhance their risk factors so they can start treating earlier than later. Majority of the time when these patients comes, they come with a chest pain and they describe, "Doctor, we feel chest pressure in our chest, predominantly left-sided. When we walk, we cannot walk. We start feeling chest. Sometimes it goes to our neck, sometimes it goes to our jaw, even sometimes to the left arm." And sometimes, especially female or older ladies or older men, they don't present with this classic chest pain. They come with short of breath or fatigueness, tiredness. Sometimes we feel pain in the arm. Sometimes we feel that our jaw is hurting. So those are some of the early signs when we think about, okay, we need to do some workup in the direction. And I think apart from that medication, we want to do some testing. And this is one of the other areas where we have speciality, which is imaging. There are different kind of imagings we can do to look into the heart disease even before we can go and fix it, which is more invasive. And that's what we come, which are interventional cardiologists.
And Dr. Tripathi, let's talk about when people don't really feel anything. So to your point, sometimes there is all of a sudden there's a heart attack. And sometimes the heart attack is the first time somebody realizes, I have a problem. My heart's not in great condition. So once we get to the center of heart practice, where you all are at, what is the pipeline of getting to you? So these are people who kind of know they're not feeling good, et cetera, et cetera, et cetera. The majority of your patients come from where? Do they come from the hospital because they've had a heart attack? Are they people that do have these issues and then they come to you? So kind of take it from that angle.
Yeah, so, excuse me. So we get two types of patients, right? So one that we see in the hospital for the first time and they had some acute event. For example, they had heart attack or they were admitted with some sort of heart problem. We take care of them in the hospital and then we make sure that they see us in our office so that we can make sure they're stable, things are not getting worse and they're stabilizing. There's other category that comes to us where either they're referred by our very intelligent PCPs, our primary care doctors, where they identify the risk factors that patient have. For example, somebody comes to them, he's like smoking, has diabetes, has high cholesterol and high blood pressure, and he's like, let's say 40s. They understand that this guy is at very high risk of developing plaque in the coronary arteries and having heart attack. So many of them who are very, very vigilant, they just send those patients to us for early testing. And then we take the history. If we identify any, flag signs, we do a lot of heart testing on them and to identify whether they need any medication from heart perspective. So that's one category. In other cases, a lot of patients are very intelligent, They just Google things online. They have family history where somebody died of heart attack. They just want to see cardiologist no matter what. They don't have any symptoms. They want to make sure things are going fine. So these are the category that we see a lot.
I like that you brought that up because we kind of have a joke on this program. Again, we've been around for 20 some odd years. And when people come and present to doctors, it's like, well, Dr. Google told me this and Dr. MD, told me this. So when people come to you and they present to you all the stuff that they think they have because they saw it on the internet, etc., how do you handle patients that come to you and they've already self-diagnosed without having real tests done? In those situations and cases, how do you handle that? And what tests are like some of the preliminary tests that you take? And I know we've already talked a little bit about this, but for example, when you're looking at arteries, right? If you have the narrowing of the arteries, how do you find that out? What is the diagnosis test to find that out?
You put a very good point right now. And, a lot of time, as you were asking Dr. Tripathi, how we get these patients, a lot of these patients, when they're in the hospital, the whole family is there, and when you discuss, I at least like the whole family is there because they have younger kids, they're younger cousins, they're a younger family. So these are the people who learn a little bit, not only from the Google, also learn from verbally. And then over a period of time, they get inquisitive. Should I look for a cardiologist? How can I prevent heart disease? Primary care, they go to the primary care and they say, okay, your EKG is abnormal. You need to see a cardiologist. Your blood pressure is not getting controlled. You need to see a cardiologist. Your blood pressure is poorly controlled. Could be you should go and see a cardiologist so you don't get this. So I think these are some of the other sources where you get patients through that education. And education is more important, as you just mentioned, that these are the people who knows and want to take care of them. These are the patients who it's easier to take care of them and make them sure that lifestyle and preventing disease is more important than
when they have that natural curiosity of what's happening, what's going on. Taking that one step further, and you were talking about smoking, overweight, hypertension. In general, what causes the narrowing of the arteries? I know we talked a little bit about family history, but say you don't know an adopted individual, for example. You don't know if there is a family history of this. What is it that causes the narrowing of arteries? Risk factors, but the reason I'm saying this too is that if people are doing certain behaviors, maybe we can throw something their way and think, well, maybe don't do A, B, and C. So what is it that causes the narrowing of the arteries? I'm going to... Okay.
So, sorry.
No, it's okay.
So, when we see a patient, obviously, the good history is very, very important, that we also look for the risk factors. Mm-hmm. So when we talk about risk factors for, blockages, we can broadly divide them into major risk factors and minor risk factors.
Oh, nicely said. Right? Okay.
So major risk factors are 4 of them, right? Smoking, high blood pressure, high cholesterol, and diabetes.
Diabetes, we haven't even mentioned that yet tonight. That's a big one.
These are the major ones. If somebody has it and his story is convincing, I don't leave any stone unturned and I just do the test just to make sure he does not have any severe blockages that requires an intervention versus medication that we need to figure out, right? And then there are minor risk factors which can help you decide whether a patient needs testing or not. And minor risk factors could be several. For example, aging itself is a risk factor. If somebody comes in 70s, then he's more likely to have some sort of blockage, maybe less or more. It could not be obstructing to the extent where it can cause symptoms, but he might have some blockages. So that is a suspicion. Then there are several others. Postmenopausal women have more likely to have blockages. And then there are certain, autoimmune diseases that can cause blockages. But these are minor ones. We mainly focus, I'm not saying that we don't focus on these ones, but we mostly see patients who have these major risk factors, they have severe blockages.
Okay.
Yeah.
And when you were talking about testing, yes, right? What are the procedures to find out what that is? I mean, is there... by all means, please.
So good points he mentioned. I think we have a lot of testing which we do. We do ultrasound of the heart, which we call 2D echo, echocardiogram, to look at the structure of the heart, look how the valve is tight, how the muscle is moving, and the valves are leaking, all those things. And there's other thing which we do is a stress testing. There are different ways of doing stress testing. Some of them we make them run on a treadmill and we monitor the EKG if there is any changes. Some of them we combine exercise with imaging perfusion study to stress the heart to see if there is any area of the heart which shows a defect or area of the heart which shows less oxygen. We call it ischemia. Those are some of the things which makes us realize that this person should be on good medical management. If they continue to have chest pain after being on medication, then we go a little bit beyond. And that's what we were talking about. We go into your arteries, we try to look into your arteries, which arteries are blocked. And if there is a narrowing or there is a blockage, we just expand that area so that we can put a stent.
See, you mentioned two different things that I want to go back to. So we talked about a leaky heart that you hear about here and there. So I do want to talk about that, and then we're going to go into stents from there and the balloon angioplasty as well. So first, since you mentioned leaky heart, leaky valves, we hear that as laymen. Don't know exactly what that means. So let's describe as cardiologists, what is a leaky valve or a leaky heart? You hear it leaky heart, but it's a leaky valve, right?
Yes.
If you can describe what that is.
Right. So, every heart has 4 valves, two on the upper chambers and 2 in the lower chambers, right? Sorry, no. I said it wrong.
I get you what you're
2 that separate upper and lower chambers, and there are 2 other which separate lower chambers from the great blood vessels that originate from the lower chambers.
You got the purple blood and the red blood.
Yes,
Okay.
yes. I'll explain that too. So when we talk about leaky hearts, it can be in any of those. And in at least 2 valves, I can say, small leak is physiological, meaning it's normal for everybody. Those valves on the right side, they can be leaky, like there's trace leaking or mild leaking, and that's completely normal. When we talk about when we should be treating leaky valve, it's mostly when it's in the severe range, meaning the role of valve is to guard the blood flow. It allows blood to flow forward and then prevents from it going back. Once valve is leaky, heart will pump the blood, it will go forward, but then come back again because the valve is not functioning. If that happens, patient will have severe symptoms. That's mostly in terms of heart failure, shortness of breath. They can be dizzy, they can just faint. And it mostly happens when the valves on the left side, something called aortic valve, it's very commonly treated valve in our structural field. Dr. Siddiqui is specialized in treating that valve through groin.
Right.
When it's leaky, it can lead to these symptoms that I described.
Right.
If it's tight, it can lead to death.
And what side is a mitral valve on? Because, full disclosure, I am mitral valve, regurgitation, leaky valve kind of a girl.
Right. So mitral valve is on the left side. It separates the left upper chamber from the left lower chamber.
Okay.
When it's leaky in the severe range, mild to moderate is usually treated by medication and usually doesn't cause any symptoms. When it's in the severe range, it can lead to a lot of symptoms, shortness of breath. You can sleep flat because you'll feel short of breath. You'll have, sometimes, chest pain or dizziness as well.
Right.
Yeah.
And I'm 57 years old. I was diagnosed with this when I was pregnant with my daughter at the age of 30. And so the way my cardiologist described it, it's chronic, but it's so far benign. So it's just something we're just looking at. But I know that's, if there's going to be a valve, that's an okay valve to have a problem with. So I appreciate you describing what that is. I don't know if we want to talk any more about valves while we're on this subject, or do we want to move on?
So I think Dr. Tripathi mentioned it very, very nicely that, he was giving an example of 4 rooms, 2 on the left side and 2 on the right side. So the red blood is on the left side and the blue blood is on the right side. So the mitral valve is basically separating 2 rooms on the left side, and the tricuspid valve separating two rooms in the right side.
Okay.
So these valves can be tight, or these valves could be very leaky. In tight, especially, we see some of the patients over here, not very common, but since we live in the border town, we see a lot of people with rheumatic heart disease. And that's a problem where
with rheumatic
valve or rheumatic heart disease because of the infection. And they come with the valve being tight, especially the mitral valve that you were talking about. In those cases, we try to open with a balloon. If they can be opened with the help of the balloon. And there are valves which are leaky. We can open by surgery, which is being the standard. But now we can do something unique. as you mentioned that you were diagnosed with mitral valve prolapse, these are the leaky valve. Over a period of time, you'll see this will get worse. And in the past, we just used to cut the chest and fix it. But now we can take by putting a clip. It's like putting a clip just like a staple, to bring two leaflet closer to each other.
And you do that through the veins, you said.
We go from the
I would love for you to walk through the process of how you do that. And I know we don't have a structural heart, but maybe we can flash it up on the screen a little bit. But walk through the process of how you do that. Where in the body do you go in? Be that guy. Give us
I think
the tour.
Again, the same thing. As Dr. Tripathi said, do 2 rooms on the right, 2 rooms on the left side. We go from the groin in the vein. And the vein takes the blue blood to the right side of the heart. So we put...
And you've got a catheter.
So we go in the catheter to the right side of the heart. We don't have to go to the right bottom part of the heart. We cross to making a hole between the top part of the heart from the right to the left. Once we go to the left side, then we can see the valve on the left side, which we call a mitral valve. And we can image with the help of imaging. That's why it's a team work. So one person is doing this, other person is showing where to go by looking at the echo, ultrasound, and guiding us where to go. And then showing us where you want to put a clip, because leakage could be anywhere. It could be in the middle, it could be on the side, and then you just go and put a clip where there's the majority of the leakage.
So I'm trying to picture what you're saying in my head. So you're going into you're in this one of the 4 rooms in there, and you're putting the clip where the valve is to keep, because the valve still has to move with every beat. So correct?
Exactly. So if you see, this is my hand. These are 2 leaflets.
Right.
So what's happening is it's separating the top part of the room and the bottom part of the room. The flow should go forward from the top to the bottom. As he mentioned, the blood does not go to forward only, but sometimes it comes back, and we don't like backward flow.
Right.
So why it's happening could be the valve is separated. Could be the valve is not closing appropriately. So what we do, we put a clip in between so that it can all be approximated.
And the clip adheres to what?
2 leaflets of the valve. Very good question. They adhere to one leaflet and the other leaflet, and they come close. Now you would put, if you're coming close, it might tight. It might get
too tight. Right.
But we take into consideration by measuring, by certain measurement. If we are too tight, we release it.
Okay.
And then we put another clip in a way that it does not make too tight.
So while you're in this procedure, you are depending on an echo to find out, once you put the clip in place, and now you're trying to figure out where and how much the valve is still leaking or not, for the lack of a better word. Exactly. Is that correct? And then you get out of there. And when I say that too, the procedure was done 3, 4, 5 weeks ago at this point. Is there a follow-up with that patient? And how do you see, after putting the clip in, how the heart is functioning? So
what we would follow with the patient symptom. Patient who come with this problem, they usually have a lot of shortness of breath. They're coming with palpitations. They're coming with dizziness. They're coming with fatigueness and tiredness because they're not getting the blood supply to the right organ, because majority of the blood which has to go out is going into the top room. So that's why we follow the symptom. Sometimes we go and look into the ultrasound again, but mainly symptom. We follow the symptom. If they are symptomatically okay, we don't go and try to look for it, because we know we are not completely we are not completely curing the leak. There is still a little bit leak.
Of course.
There is, but we are taking care of the majority of leaks so the patient can feel better.
Okay.
And over a period of time, the heart function does not get worse, or even it start getting improved.
Okay. And then here's another question, and then I'll leave that one alone for a while. This clip, how long does this clip last? Does it last forever?
It lasts forever.
Okay, yeah.
It's once it's inside, we don't take it out.
And what's the material that it's made out of?
It is metal.
Okay.
It's a metal piece.
It's a metal clip in your heart.
In the heart, yeah.
Okay.
Yeah.
All right. So when you fly to Paris, is it an issue?
Nope.
I'm joking.
It's you can get an MRI or
small
anything.
Mix.
In one day.
I want to go from the clips now, stents. stents are such a big deal in the world of cardiology. And I know we talked a lot about this last time that we were on the program together. So when does somebody should have, consider a stent? When do you look at a patient and think, okay, these are things happening within their heart. This could be an option for a stent.
Right. So, we put stent in patients with blockages in the coronary arteries. We can broadly divide them into two categories. Right?
Okay.
One, those who come with heart attack. Then there is no question. If we find a blockage and he's a suitable candidate, we have to put a stent to save his life.
Okay.
Right? So that's an acute condition. And then we see some patients who have something called stable coronary artery disease, meaning
stable coronary
artery disease, meaning they have certain degree of blockage in the coronary artery, which is giving them symptom only when they exert.
Okay.
But gets better when they rest or take nitroglycerin.
Okay.
So those patients, we initially, we do different testing. If we don't see any high-risk features on any of the tests, we try to treat them with medications first. As Dr. Siddiqui said before, if their symptoms go away and they're feeling better, we don't do anything beyond that. But let's say we are treating them with medications and their symptoms are still there, they are not able to do things that they enjoy, then we discuss about putting a stent in there.
Okay.
And if they are agreeable, if they understand risk and benefit, then we put a stent there to alleviate their symptoms.
You also hit on something there when you're looking at risk and benefit, right? We did completely on a different situation, but we just had a prostate cancer program, right? And a lot of that program was risk and benefit. In the world of cardiology, I feel like that's not necessarily the case. There are certain things that you need, but in what you're talking about, when is there a risk and benefit? And this is kind of not the negative part, but there is a tiny bit of a risk with everything that we do. Yes. What are some of the questions that you get from patients before you do a procedure? Just some of the common questions. And I like for actually both of you all to chime in on that, because you talk to patients and, to your point, and their families. All 20 of them are asking you questions. And I'm always curious of what kind of the questions are you all receiving before a procedure? How do you put them at ease? How do you calm them down and say, no, these are the things that are really good? And I'll start with you, and I definitely want you to chime in.
Sure, yeah. So, first of all, when we talk about stent, the first question is, how do you do it? So we explain them what we do. We puncture you here or in the groin, and then go inside with wires and catheters, and then they start talking about what are the risks. So we tell them about, the risk of, normally the stenting that we do, it's less than 1%. But majority of the risks are complications are very simple. We treat them very easily, but in rare cases, extremely rare cases, 1 in 1,000 cases, people can die while having procedure because, again, it's a procedure, right? We go inside, we are advancing wires, catheters that can go sometimes in different direction that we would not want, cause dissection, can close the vessel, cause injury to the heart. So they need to know that hey, there is 0.1% risk of death while doing the procedure. If they understand and accept the risk, then we offer them the stent. And there are other common, not very common, but there are other risks which can be managed easily. For example, bleeding, they can have swelling, pigmentation, they can have kidney injury because of the contrast that we use. So there are other things that can happens in very small percentage of patients, but we need to tell them.
But they need to know what that reality
exactly.
is.
So I also make sure that they understand the risk and benefit. So because it's important, every procedure has a risk. The risk doesn't negate. I always tell them that you drive from the hospital home, something can happen,
right?
But still you go over there, and because there's benefit of you going to home. Right? So we do the same thing. If we would not have any benefit of the procedure, we would not do this procedure. Right. But it comes with a risk. The risk could depend on the condition you come with. If you come with a condition of a heart attack, which is more an acute situation, your risks are higher of having complication. And one of the complications which is unavoidable is death, which can happen. And certain situation when somebody coming with a heart attack, the risk is dying is 50% by not doing anything and by doing something. And
that's the benefit of the risk comes in.
Exactly. And somebody who's coming not in acute situation, in a more chronic situation, then their risk is a little different. And as you mentioned, 1 in 100,000 people can have a risk of having a complications.
I'd like to talk about, because Dr. Tripathi, we talked a little bit about this in the last program, but drug-eluting stents. which I thought was fascinating. So you have a stent, but it's doing more than just keeping something open. It is providing treatment, so to speak, in the heart. Describe what that is.
So our stent, basically, that we use, it's a metal tube that sits on the balloon, and we go to the coronary artery and we find the location, and then we basically inflate the balloon, and that deploys the stent, right? That's how normally it works. Now, in I would say 10 years back, there was something called bare metal stent, where we did not have drug inside the stent. It was a good option because we just started doing these procedures in 1990s, and we did not have a lot of technology. Those are good, but the problem was that scar tissue would grow on these, and it will block the stent after 6 months to 1 year the patency rate was very low.
Okay.
Then now we have a lot of research going on. Now we have third generation drug-eluting stent, and what they do is that they're like different drugs on that metal tube that will prevent scar tissue to grow, and that's how it will keep that metal tube open and will allow blood to flow for a long period of time.
So a lot of time we call it that the metal has a polymer and it releases the drug. The main reason is this drug gives time for the artery to heal, and the stent can be part of your own artery.
So you were talking about stents are in there also forever. How much of this drug or this medication is there? In other words, how long does it elude this medication? I'm assuming there's a certain point where, okay, we're done, now it's a stent, but the medication's all gone. Is that a couple of months? You said the healing period, a couple of years. How does that usually work?
The initial phase where the most drug is released is within the first month.
Okay.
And that's why a lot of time, if anything happened, it happened during the first month, if the blockage happened or anything. And the majority of the scarring happened in the first month more than the later part of the year. Okay. We have stents now where we call it bioabsorbable stent, which
bioabsorbable stents. Okay.
Again, this is a stent which it's a delivery system where the drug is given, but over a period of time, the stents absorb and you don't see the stent.
Huh.
But this came into the system for last 3-4 years. We are learning that there's still more room to grow in that in that part of the stent. So we are still using a drug-coated stent, but we have learned that there are stents which are called bioabsorbable, and in future we'll learn more about it. But it's not very commonly used right now.
Okay.
But there are different kind of stents.
So part of this program also is trying to figure out what's happening in the future. So when I hear that the stent is being absorbed by the body, does the artery then little by little start to close again? Because I'm thinking stents that are in there forever, and I don't know. So say somebody in their 40s, unfortunately, but this is something they're having. So now they're in their 60s. This is a stent that's been in 20 years. Give me an example or a case study or two where someone has had to go in and either replace a stent, if it's a bioabsorbable stent, does the artery then just stay open because there's that medication that you were talking about? And I'm just looking for what you all have noticed and what might be natural questions for the audience to ask while you're speaking about this.
So these metal stents, which we are talking about, the usual drug-coated stents, these stents are metallic. They always stays in this.
I see.
It never get reabsorbed.
Okay.
They can get occluded. They can get occluded over a period of time, or they can get occluded suddenly. If it's suddenly, it's different mechanism, which means the clot is formed in the artery because you are not taking medication. It can block over a period of time because you were not taking good care of yourself. You were not controlling your diabetes. You were not taking care of your blood pressure. You were not taking good care of your cholesterol. So this built up over a period of time get blocked. And if they come sometime, we have an option to put another stent inside the stent, or we have an option, then we can get a bypass surgery also.
Okay.
It all depends. Bioabsorbable stents, if they are absorbed, the artery stays open. But the only way the artery would close is the same reason. If they're not taking care of their conditions, diabetes, high blood pressure, cholesterol, same thing, which we get the disease the first time, they also get the disease the first time, the same way as
So it's not like you guys go in, yes, you fix things for that time, but they still have to make sure that their behavioral health, so to speak, of how or what they're doing in that area makes sense. We talked a little bit about, but we haven't really, I feel like, haven't completely explained it, the balloon angioplasty procedure. So compared to stents, what is that procedure? And again, because you guys both kind of do the same thing, I know you're more structural. Explain that first, and then we'll go from there.
So balloon angioplasty is actually part of putting stent.
Okay, so that is how you get the stent in.
Yeah, so if we see a blockage there,
okay,
we first go inside, prepare the lesion. For example, we go inside with a balloon, inflate the balloon to allow room for a stent to be delivered. And then we do different testing to see the size and all that. So balloon angioplasty is not a separate procedure. Before we had stent in 1990s, that's what we used to do. I think when we did not have stent, we'll just go and balloon it and open it and just leave it. But that has very low rate of patency. Basically, the blood vessel will close over a period of time.
Okay.
Now we do balloon angioplasty followed by stenting. We put a stent. Yes.
And in my head, when you were saying the bioabsorbable stent, I thought to that point, you're putting a stent in and then your body just absorbs, but that's not necessarily the case. Okay.
But there's one more thing I wanted to add, but which is not available in America,
in America,
I guess.
and that's what we wanted to talk about.
Well, then let's do that, because we've got like 16 minutes left, so let's...
I'll let Dr. Siddiqui talk about it, but there's something called drug-coated balloon, and I think Dr. Siddiqui will tell
this
more.
is something which
Say that slowly. It's called what balloon?
It's called drug-coated stent, drug-coated balloon.
Drug-coated balloon.
So it's not a stent. There's no metal. It's just a balloon coated with a drug. And this is the future. This is the future. A lot of trials has been done, especially coming from your country. It's already getting it done over there in Germany and other European country. And as we have to go through a lot of trials and study before we can do, and you'll see in the next 2 months, November 2024, that we're going to start drug-coated balloon.
Months?
Yes.
Oh my goodness, this is right on
the It's already approved here in US.
We're going to, and this will make a big changes that we don't have to put a stent in these arteries, which are smaller arteries and which can be fixed just by balloon, or arteries which are longer diseased artery where you put such a long metallic stent, we can just treat with the balloon and they will stay open.
So when you say the balloon is not staying there. You're going in there, you're like a drug-coated balloon. You are diffusing the medication within the artery. Is that what I'm understanding?
Exactly.
So you're doing that, and it's a procedure, and then the medication stays there, the balloon comes out, and then life is good.
Yes. And we are already using this balloon in the arteries of the legs.
Okay.
But we haven't used in the arteries of the heart.
But you've been using that in
need to have this conversation, because I'm just going to sit back and listen for a while. I really don't know what questions to ask, by all means.
No. I mean, as you said, I mean, this thing has been, the European has been using drug-coated balloon for like 3 years, but it's not approved in US for some reason.
Okay.
Now they realize, this is a good option. Now it's FDA approved a couple of months back. So hopefully we'll have drug-coated balloon ourselves, probably in November 2024. And then we'll start using it and we'll see how does it work, whether it's useful. You know, we're going to get experience of it and then decide if it has good long-term benefit or not.
This may be an unfair question to ask. So when FDA, et cetera, when something is being used somewhere else in the world and FDA approval, which is great and very important because we need to make sure it works, how then does the process of getting something that's happening somewhere else come to America, which you said is approved, but now we're looking at El Paso. Who gets it? Are there grants that are being applied for? Is there equipment that comes in? Like, talk about how in the next 2, 3, 4 months, you said 2 months, how that enters into our system here in El Paso. I think people are fascinated. It's like all of a sudden it's there, but how did you get there?
So just like how all these other devices come, it has to go through the value committee meetings, it has to go with the protocol, and it has to go at the administrative level of the hospital, and then come to our cath lab, and then we are ready to use these.
Okay. So when you said in the next 2 months, are these already in place? No. And let's talk about training. Because training's a whole thing. And what I love about, especially our community, there are trainings constantly, and it's not like
Education.
you're a doctor, you got your degree, you're a doctor, you're getting trained constantly. Every several months, you're going to a training. What is the training specifically on this procedure?
I don't think we need special training. It's just a balloon for us.
Okay.
It just has drug coated on it. So we have been using this forever. So there's no special training needed for us, I guess. But
anytime you have to bring in the cath lab, you have to educate. Educate because it's the teamwork. It's not just us. It's the technicians who are working in the cath lab, just the nurses. So we do in-services before we do it. And again, once it comes in the United States, then it will make its way to El Paso. Once it comes to the El Paso, it has to go through the process. And for the hospital to have all the things taken care before it can come to the hospital. And once we know it comes to the hospital, then we do specific education for ourselves. And because a lot of time it's the same thing, but there are different ways of putting it.
Right.
Just like we put the balloon right now in the legs. We have to open the balloon slowly, right? And not in 10 seconds over the 2 minutes. We have to leave it
So the
inflated.
elasticity is a big
we have to
point of
leave it
that.
open for
Right.
2 minutes. Again, in the leg artery, we can keep it longer. In the heart artery, we cannot keep it that longer. So all these things has to be taught to the technician, to the cardiologist, and we go through the in-service from the companies who is providing this device. Again, it has to go through a lot of rigorous process before we can start doing it.
I love that explanation. Do you have anything to add on that? I know we are kind of at that, and I promised you all that usually at about the 15 or 10 minute mark that I stop all the questions from me and ask what it is that we have not spoken about yet this evening. So I feel like this is one of those. I mean, we can continue doing that as well. But is there anything else that we have not spoken about yet this evening that you really want to talk about before we start wrapping up the program? And we can totally continue going on this because this is brand new to me.
I think a lot.
Yeah, we already covered. I mean, I think DCB was something that could have been the answer of this question.
Right.
But we just spoke about it. Otherwise, I mean, we touched like every aspect of interventional cardiology, structural cardiology.
More out there.
I'm sure there's a lot.
What do you see? And I know I'm pie in the sky, but 20 years from now, I mean, really, this is something you guys are doing. And 20 years from now, I feel like it's a really long time in the future because we're looking at things that happened the last 5 years that we didn't expect to be happening 5 years ago.
Yeah, that's true.
So if you had a pie in the sky, I would love to be able to A, B, and C 20 years from now. What would that be that you do see as a bit of a possibility in treatment of heart disease, arteries, etc., valves even?
I think medicine is growing, and we would be seeing so many development over a period of time. We're already seeing in the
genetics. I feel like is such a
game, and I think now we are seeing, not only fixing the valves, not only fixing the arteries by using minimal device, putting a pacemaker, which one time it used to be such a big generator. Now it's like a small generator. Now we don't even have to put a wire, and we can put a pacemaker in the right side of the heart.
And let's talk about the phone too, that you can
exactly monitors
what's happening with my heart right now. So
exactly. Now you can talk about, you can put a patch, you can have a watch, and you can see what's your heart rate, what's your blood pressure, what's your rhythm, and and now we are heading into artificial intelligence, and you would see that they will help us in diagnosing, and we would just be in the cath lab and we'll be doing the procedure on patients. A lot of things going on. Robotic surgeries are going on, gene therapy is going on, stem cells are going on. I think in 10 years we're going to see more translation from animal to human, and it's already more maturation in that area, where we would be able to give different treatment by genes and by the stem cells.
So we joked a little bit before we went on the air about your Star Wars cap. But when you talk about that in AI, I think about Star Trek. Remember, and we're old people. I'm old. I'm 57 years old. And Bones was on that show. And Bones had, let's pretend it's the phone. And he'd go over the body, and he was able to diagnose everything. And in my head, I thought, yeah, right, whatever. But we're almost there on that note. We're almost at the point where we have ways of diagnosing people that we didn't think about way back when. And so when I asked earlier, when someone is having a problem and we were talking about contrast that's going into the body and you're able to follow all these things. And I'm going to go back almost to the simplicity of this program and ask, how is it that you diagnose somebody with heart disease that doesn't have symptoms? I know there's not a screening per se, but I feel like when Bones did this, it was kind of like a screening. So is that something that you see in the future, that there is, like you go to the Mayo Clinic and they do 12,000 tests on you that day? What do you see in the future as far as finding out if you are someone who's prone to heart disease, if you've had no family history, if you have no idea, someone appears to be in perfect health, and then boom, they drop dead of a heart attack while they're on a run on a Saturday? How do you know, and how can we find out these issues with people? And both of you guys are nodding like, oh dear God, Catherine, I don't know how to answer that. But I'm just throwing it out there. Who wants to take it? Like, how do we know?
It's very difficult to, as of now at least, it's very difficult to, there are certain conditions where you just can't predict what's going to happen. There are a lot of, young people dying of sudden cardiac death. They don't have any risk factors.
Exactly.
Yeah, I think 2 months back, I just did a STEMI on a guy. STEMI is basically heart attack. He was just 34. He was avid marathon runner.
Oh my.
Yeah, no risk factors at all. No family history, not a smoker. He was a physician actually in El Paso. I can't take the name, but he came with STEMI, anterior STEMI. The LAD was blocked. He had cardiac arrest in the ER. We took him to the cath lab and 100% blocked artery. I was like,
100% blocked artery.
I checked his labs, cholesterol completely normal. LDL was like 67 or something. No risk factor that I could identify. We don't have tools yet, honestly, to identify these people, but maybe in future we have certain things. There are a lot of things that we don't know yet, lipoprotein A that we really don't utilize. Now people have been talking about that thing. Mm-hmm. So honestly, there are a lot of research going on, and probably we'll have more markers in future than what we use here right now, the LDL and the traditional markers or blood work. And there are certain tools that we use right now. We'll have more of them. A lot of research going on. There are a lot of things that we don't know yet. Mm-hmm. Yeah, but honestly, I don't. It will take time, but it will happen, I know.
I'm going to ask, go ahead, please.
Yeah, so I think we follow the guidelines which have been built on the basis of multiple studies, which have shown benefit in multiple studies. Mm-hmm. I think if you start doing testing on people who don't have a disease and don't have a symptom, you're going to put a lot of economic burden.
There's going to be panic everywhere.
And not only if you try to find certain things, you would overdo things which might not be necessary. I still feel preventive cardiology and treating if somebody feels something is more important than just looking for the disease if somebody doesn't have a disease. You can put a scan. We don't want to put anybody in a panic. You can do a stress test on 100 people. There might be one person or 10 people might have a disease. You do a CT scan, coronary calcium score, you might find the score is 1800. Again, that might help us to change their lifestyle. Mm-hmm. But does that mean that we need to look more if they're not feeling symptoms? I think that's where we still need evidence for that before we even go that far.
I want to do a quick public service really quick, and the AEDs that people see all around. And I just want to ask really quickly, because I know we don't have a lot of time, but the automated external defibrillators. We see them in airports, we see them in shopping malls, we just see them around. What are they? And in the general populace, is there any kind of training that, when are they used? I guess that's the question, right? You see them around, it's like, oh, if somebody's having a heart attack, get one of those. But what do you do? Because there's not a medical person around. I don't want to spend a lot of time on it, maybe a minute or two. Who wants to take that really quick?
Sure, yeah. So, so we undergo training, something called, BLS, basic life support and advanced life support. Mm-hmm. And we as physicians or medical professionals, we are trained to identify who is having cardiac arrest and who will benefit from getting shocked so that we can bring them from death eventually, right? Mm-hmm. So this is what AEDs do, automatic defibrillators do. Basically, if somebody just collapses, let's say he's walking in mall or airport or whatever, collapses, he does not have pulse. If I know that a lot of general population is now trained in these things as well. They can identify the patient and they can bring that device, connect it to him, and that device will guide them whether a patient needs shock or not. They will identify the rhythm, they will tell, okay, rhythm is shockable, you can shock patient now, and this can make a lot of difference. It will guide them to do CPR at certain times, stop whenever patient needs to be shocked. So I think it's a very good device. It has saved a lot of lives, but I don't really know what is the education for this device in general population.
And when I'm talking, I just thought I'd bring it up, and that's on me really, because when I came into this program, I thought I want to spend at least 5 minutes on describing what that is. So we'll do that in another cardiology program because we got all excited about this other stuff. But I'd like to, at least when people see that, for them to know what it is, and maybe in a cardiology show in the future, we can actually spend a little bit of time, bring one in, show people what it's for. Again, it's not necessarily for the lay person, but maybe there's someone who's worked a little bit in healthcare that kind of understands it, and we can kind of take it from there. But anyway, I just want to say thank you so much again, Dr. Tripathi and Dr. Siddiqui. You guys have been wonderful. I've learned a lot during this program, and in case you tuned in late or want to watch the show again, there are 3 different platforms you can do that on, and I love that. Once this airs, you can go back and link to this program. It's going to be there forever. But pbselpaso.org, just look for the words, the El Paso Physician. The logo will be on that screen. Also, EPCMS, which is the El Paso County Medical Society website, and that's epcms.com. And then YouTube, this has been around forever. And with YouTube, you just have to type in the words, the El Paso Physician, and it usually comes up with not just this show. It'd be this show, it'd be the show that we did back in February, and all the different programs that the El Paso County Medical Society does with the El Paso Physician. So I think that's so super important. And if you ever have a question also about the program, feel free to email the El Paso County Medical Society. But I know that we're running out of time. Thank you so much for being here. I'm Catherine Berg, and this has been the El Paso Physician.
Good evening. I am Dr. Allison Days, a past president of the El Paso County Medical Society. The El Paso County Medical Society has put on the El Paso Physician TV program for the last 26 years. These programs are archived on kcostv.org, epcms.com, and on YouTube. You may access the programs at any time on these websites. If you have questions on tonight's topic, please reach out to epmedsoc@aol.com, and we will try to get your questions answered in a timely manner by an expert in the field. Thank you again for tuning into the El Paso Physician tonight.